Hey class, this is Dr. Ang. I'm coming back to you. This is our third video in the sequence of disruptions for activity and rest. Today's video is going to be over multiple sclerosis or MS. We have went over cerebral palsy, CP, muscular dystrophy, MD, and now multiple sclerosis or MS. There are a lot of things that are similar, but then there are some cardinal signs that are different, and that's the ones that oftentimes you'll see on the NCLEX and things that I'm going to want to point out to you as we go. So I'll do a little reflection back to our initial first two videos as I go through for MS, going over that. As you're studying for this, if you have any questions whatsoever, obviously first rewatch the video, reference in Harvey. I've showed you some different areas you can go to, whether it's the text, whether it's some of the videos or the resources available. Also go to the official sites. Typically you can go to multiple sclerosis, you can go to muscular dystrophy or cerebral palsy. .org.com. There's several ones that you can look at, and I have some of those available on Harvey as well. And just educate yourself there. If you have further questions, send me an email, shoot me a text, whichever the case may be. And if you would like a little more face-to-face, we can schedule a Zoom and take a deeper dive in any of the three videos that we've went over regarding disruptions of activity and rest. But today we're going to hit MS as we go. So when you're thinking of multiple sclerosis, it's a chronic progressive autoimmune disorder. So which one, thinking back, referencing back to CP and MD, which one was progressive? I'll give you a minute to think about that. Which one was progressive? MS is progressive, and also MD, muscular dystrophy, is progressive. Cerebral palsy is non-progressive. It is permanent damage, so it can't be cured, but cerebral palsy is not progressive. So wherever that injury occurs, that's where it'll stop. It will not progress. However, the signs and symptoms, if not managed properly, can appear to progress from signs and symptoms, but the overall disorder does not progress. So for multiple sclerosis, though, it does. There is a progression with this disease process, and it is a demyelinization of the nerve fibers. So when you think about a neuron, if we were in class, I would draw this for you, but you're firing off a message, and then you have the receptor that wants to receive that message. And you have your nerve fiber, and it is insulated with a very smooth, cushy myelin layer that surrounds that nerve fiber. Sorry, while I log in here. And if that myelin, it serves as that superhighway of helping the message get from point A to point B. So whatever the brain, if we're talking about the central nervous system, whatever the brain, the message the brain is trying to send out, let's say on a motor pathway, and you're trying to tell the foot to kick a ball, okay? The myelin helps that message to be flawlessly delivered in a very timely manner, split second or less than is the myelin. It's that smooth highway. When you're driving in a car to get from point A to point B, there's no traffic, there's no potholes, there's nothing falling in the road or any detours, because that myelin is that smooth, super speed highway. Now, if you've ever been on a road with potholes and excessive traffic and detours, that's what it's going to be like once there is damage done to that myelin layer. And that is going to show when my brain is trying to send a motor pathway message to my foot to kick a ball. If there's damage done to that layer, that can be seen in a delayed reaction or not being able to get the message to the foot at all, depending on the severity of that damage. So myelin layer, critically important. in delivering that message in multiple sclerosis. So demyelinating disease of the central nervous system is, in short, the definition. Demyelination of the central nervous system. And just think about it, though, as that pathway where you're making a call and you're trying to get a message from point A to point B. If that person can't hear you or it's dropping the call, whatever the case may be, it just prolongs or makes the process more cumbersome as we go along. So, again, if you look on that second slide, you can see the central nervous system, the brain, and the spinal cord. You'll see that myelin sheath of a healthy nerve, and then you'll see the axon. In multiple sclerosis, the myelin sheath, which is a single cell, the membrane wraps around the axon, and it's destroyed with inflammation and scarring. And interestingly enough, we have the blood-brain barrier that's obviously trying to protect the central nervous system. And in MS, an individual's own immune system somehow penetrates that blood-brain barrier, and it gets in and starts attacking that myelin sheath, which then will have bouts of whatever the case may be. Inflammation is what we're going to see left by once it subsides. It will leave slowly over time damage done to that area in the brain that will be known as a plaque. And when you do a scan, and you can see over time there will be increased lesions or plaque that you can see that have been done over time. And originally, when you have an early diagnosis, you'll see there may be a bout or a flare-up, and then it subsides. And then during that time, the body can remyelination. It can reform that myelin layer over time. But eventually, in the case of MS, the immune system overpowers the ability for it to regenerate that myelin layer, that myelin sheath, and pretty much the immune system wins by attacking what you want to be there. So it's your immune system is attacking yourself. This is not something outside that gets in. This is your own body basically attacking this myelin layer. And you can see I have another chart over here that kind of shows the progression of MS. So some specifics for MS. It, again, is chronic. It's progressive degeneration of the disorder of the central nervous system. Disseminating demyelination of nerve fibers of the brain and spinal cord. So all of our message control center is the central nervous system, and that is being attacked. So there's patchy insulation resulting in short circuits. So where we're trying to send out a message, now it's going to be harder. You maybe can still get the message, but it may take longer, or it may not get there even at all. Women, as I've mentioned, this is the difference also with MS. It tends to be more women, whereas CP and MD tends to be more males. Women are affected 2 to 3 times more than men with MS. Whites more frequently than Hispanics, African Americans, and Asians. And then cases in the U.S. tend to be annually 350,000. So this is a little more common as well. So you can see there are 4 types. And the most common is the relapsing and remitting. And this is a phase where you can, I think I have a graph here in another slide, but I just kind of want to touch on it here. This is where a relapsing and remitting is, you will have, it's the most common type of MS. And there are bouts of autoimmune attacks happening, and it can be months or even years apart. So you can have a bout where someone, a young female, may come in and say, I don't really know what happened, but I had some difficulty with speech some vision problems, and I had some tingling or pins and needles sensations. I'm not sure what it was. It lasted, a few days. And then by the time I got in to get checked out to see what was going on, it went away. So I just let it go. And then it may be weeks. And again, the crazy thing, or it's difficult to diagnose because it may be weeks or months, and even early on, it could be years in between. Then it'll happen again, and it's a progression. There'll be a bout, and then it'll level out. And then there'll be a bout, and then you'll level out. But as you notice as I'm going, you don't drop down the baseline, okay? It's about, and then it stays, and then about, and then you go. So you're having damage, but you do level out for a while, and then another bout, and then you just keep climbing up that scale. So it's progressing, but it's not progressing just at a steady rate. And when you put weeks, months, even early on, potentially years, you can see why it would be hard to diagnose in that case. And that's progressive and remitting. And let's see here. So let's say, for example, during a bout, a person may have loss of vision followed by improvements while they're in remission. And if there's a remyelination, typically the remyelination process isn't fully complete prior to another bout taking place. And that's where you'll see the damage that's irreversible. With each attack, more and more of the central nervous system becomes irreversibly damaged, and that's the debilitating part about MS. Interestingly enough, there is typically no increase in disability between bouts. So there again, you may find justification. I must have just been really tired. Maybe there was something else going on. I'm not really sure what was going on, and then it goes away. So then sometimes you'll just put it on the back burner, and that's why it's difficult to diagnose, and it's difficult for the individual to even kind of work through and unpackage what's going on. Then we have secondary progressive damage. Initially, it's similar to the relapsing remitting type. However, over time, the immune attack becomes constant, which causes a steady progression in disability. So that's going to be the third time. The one I didn't, relapsing remitting, I'm going to make sure I'm going in order with these. Acute attacks with full to partial recovery between attacks. So then the primary progressive, you're going to have obviously more bouts in between, and you're not going to get healed up from it and be able to form that myelination in between, and then it continues to progress at a little faster rate. So going from, as you'll see here, from the relapsing remitting is obviously, it's the most common and then the most treatable because you generally can recover in between. Then the primary progressive is what I was mentioning, as you're climbing a little faster, secondary progression, and then it leads up to progressive relapsing, and that is going to be at a much faster rate. And like I said, I think I have a chart in here that's going to show it. It's a little more of a visual that's going to be more helpful to you here. So yes, here it is. So the relapsing remitting, you're going to see it's that blue line. So it's the most severe disability. You'll see is on the vertical axis, and then time you'll see along the bottom, and then you'll see the more brown orangey line is secondary progression, and that indicates secondary progression initially similar to relapsing remitting type. However, then over time, the immune system becomes constant and it's attacking, and it begins to be a little more aggressive. So a steady progression of the disability. Whereas, like I said, relapsing remitting, most common type of MS, and you can see the onset followed by bouts with periods of a remission, and it's just longer in between bouts. That's typically where it will start. Then you can see the green line is primary progression, and it is a constant attack on the myelin with steady progression over a person's lifetime. So disability progresses quickly, and there's not really a point of of remission. You're going to just see it's just kind of that steady incline, primary progressive. Okay, then lastly, you're going to see that red line, and that is progressive relapsing. And that is one constant attack, just a constant attack of the immune system on that myelin sheath with bouts of superimposed. Okay, so not only are you going progressive, continually progressive, then you're going to have even further, more severe bouts. And it is going to be more debilitating and more aggressive. The most aggressive form of MS is going to be progressive relapsing. Hopefully that, it kind of sounds confusing all the jargon that I said, but when you take a look at that visual, I think that it will be make more sense to you. And as I have mentioned, please know just kind of what's the most common. Know that MS is generally more females, diagnosed between the ages typically at 20 and 40. Those types of things are going to be the critical aspects that you're going to want to know regarding MS. So lesions, we're going to look at our spinny wheel here. Acute initial inflammatory response, and then chronic lesions, scarring, and then it creates these forms of plaque. So where the lesions are, it forms plaques that do not cannot repair themselves, and that's going to be permanent. So think plaque and permanent, and also what we see on a scan to know and help a definitive diagnosis for MS. Generally affects women between the ages of 20 and 40, as we've mentioned. Myelin sheath destroyed. The axon is involved, so sending that message on the neuron. And just think, if you're sending either sensory pathway or motor pathway, either way, the message, there's a disruption. So depending on the severity, is going to be what the signs and symptoms will be for that individual. And perpetuated by faulty immunoregulation. So for some reason, inside of this, generally female's body, there is going to be an attack by your own immune system to bust through that blood-brain barrier and start attacking that myelin sheath. And just knowing the key, it's perpetuated by a faulty immunoregulation system. Okay. Chronic inflammation or demyelinization, and then scarring of the central nervous system. Going to be the key for that. I have another video here just showing a normal nerve cell. I like to show you kind of what's normal, and then it'll help make sense for the abnormalities that are associated with MS. So you'll see that nerve fiber in the myelin sheath. The nerve fiber is running through the center in that insulated layer. The nice smooth insulated layer on the upper half of this slide is showing you what the myelin sheath should look like. And then you drop down below that and you'll see a slow degeneration of the myelin. You can see originally this is probably, maybe 5 years in, 5 to 10 years in. You can see then on the very bottom of the slide, that's further destruction to that layer. So it's a pick of an axon nerve fiber and then a healthy coating of myelin, and then contrast when the myelin has been damaged in the case of MS on this slide. So here is a little more pathophys if you want to know this, just kind of recapping what I have already said. But axons are spared in acute and early phase, but then as it begins to, it's kind of a battle between the immune system, and then you have that myelin sheath that's just trying to repair itself, but then after time it just gets wore out and it's overpowered by the mighty immune system attacking. Remyelinization occurs if not interrupted by further disease. But as we mentioned, there are the 4 types. When we're looking at the relapsing and remitting, you'll get that time of rest where some remyelinization can take place. But if you're going more to the final 2, you can see it's just at a steady progression where there's not that time, there's not that pause or that plateau when it can remyelinate itself. So that's where the further damage will come. It's more aggressive. So obviously the disease process will be more aggressive. The signs and symptoms will be more severe. Axons are destroyed in complete conduction block in advanced stages. So we don't go from just a mild disruption, we go to completely not sending the message, cannot receive the message at all. First attack, complete recovery, and then no more you can have for several years, and then you can get where it just, the bouts in between and the pause, the remission gets shorter and shorter and shorter, and the bouts become more frequently, thus increasing the plaques and the lesions. So how does it impact the body? Again, depending on the location of the lesion and the central nervous system, being the brain or along the spinal cord, will indicate the disability that will correspond to that area. So brain image of MS will indicate a lesion or a plaque. Then they occur in different parts of the brain, and we know that different parts of the brain are responsible for different functions, so wherever that takes place. And we know then it's not just an injury and then you bounce back because it remyelinates itself. Once it's permanently a plaque lesion, it's destruction and it cannot repair itself. Now that damage is permanent. It could be as severe as paralysis. So that's how you see that it progresses, the more damage that has been occurred. For example, different part may be reversible for vision or movement, touch, cognition, or even emotion, whereas dysfunction can occur in a variety of areas to the brain. And then symptoms are reported, making MS very difficult to diagnose. If someone comes in with vision problems, we might not automatically suspect that this is MS. You may come in with speech problems and not automatically think that this is MS. You may come in with motor functioning issues or loss of balance, and you don't automatically think that that's a diagnosis of MS. It's over time when these signs and symptoms start to stack up, and we can get some time of, okay, now I had this happen 3 years ago, and then I had it happen last year. Now I've had it happen again. I'm starting to see a repetitive cycle. Here are the things that I have jotted down and that I have seen, and we put the whole picture together. Then we go in for a scan to see, and the plaque is noted. Then it can be a definitive diagnosis of MS, but it's not going to be initially. The first signs and symptoms are not easy to pinpoint to MS. Remission. After onset of symptoms, remission is typically 1 to 3 months, and it may even be years. It's different for everyone. Anyone that I have conversed with regarding MS, everyone's story is very, very different. And again, this is primarily females, but there's a significant amount of males that are affected as well. And the impact that it has on one's lifestyle is very, very different depending on the type of MS that they have, and then the progression and how aggressive that their form is. And then as well as when you have time. Do you have time for your body when you're in remission? Is there time for it to repair itself? And then how long, also how early was the individual diagnosed? Then you're going to see as far as that affects the progression as well. And some people with the diagnosis of MS, it can be unpronounced to anyone else that they even have MS. And then some you can see where it's a little more aggressive, and they be maybe fairly young and in a wheelchair at that point. So it's just every case is different. But just I want to get that message across. It is very difficult to diagnose because it takes years of documenting one's health patterns before you can paint the full picture and get a definitive diagnosis that will prompt a scan to be checking for the lesions or the plaques in the brain or the white matter. With successive attacks, exasperations, recovery is not complete. This is also a term that's used, is exasperations. After each episode, you'll have more permanent and extensive damage. Behaviors, the onset is insidious and diverse in presentation. Like it's diverse. For everyone, it's going to be different. And it's insidious. It's very hard to diagnose. Signs and symptoms depend upon anatomical locations of where the plaque formations will occur, where the injury occurs on the central nervous system, whether it's the brain, the spinal cord. Similar to when, if it's an injury to the spinal cord, wherever that happens, below is where you're going to see the damage. So 2 out of 3 exacerbations with near complete remission, 50% remain ambulatory. Then 50% were going to require assistance. Clients rarely hospitalized, but frequent doctor's visit attempting to make sense of the symptoms. This is going to be the female that's like, something's not right, but I don't know exactly what it is. So I go in, I try to seek care, but by the time I get to a couple appointments, now I'm back in remission from it. So you see that kind of roller coaster ride. And again, until you get a little bit, it's going to be that frustrated person, like something's not right, but I can't quite pinpoint what it is. Symptoms include motor, sensory, cerebral, and emotional signs and symptoms. Cranial nerve impairment is going to lead to, so if you have an attack, okay, on the myelin around the cranial nerve, this could lead to signs and symptoms of blurred vision. You can have double vision. You can have a sense of, it's been reported, loss of coloring, loss of sight, transient, nystagmus, and you're going to the eye doctor, you're trying to figure out what it is, and then all of a sudden it's fine. So then you go into that state, that plateau of remission, and it can be fine. Which leads to the frustration with it as well. Motor dysfunction can be, so on the motor pathway, can be fatigue, dysphagia, weakness on one-sided, paralysis, tiredness, poor foot control, abnormal gait. It can be spasticity of the muscles, joint shaking, tremors. Then you have the motor pathway, and you also have the sensory pathway as well. Paresthesia. You can also have a sign that's very specific to this as well, is going to be one that I want to make sure that we go over, is the Charcot's neurologic triad. This is an interesting one. This is one that is specific with, when we have these three, it points more pointedly towards MS, and that is dysarthria, which is speech, difficulty with speech and swallowing, tremors, which is affecting balance and the motor pathway, and then nystagmus, which is vision, rapid eye movements, and that's going to be damage to the optic nerve. So if you have a damage and the lesion is occurring near the optic nerve, okay, and then it's in the early stages and it's repairing itself, then you're going to have your vision come back. Or whatever the case may be, if you were having double vision, then all of a sudden that clears itself up because you're in remission. Then it repairs itself during this time. But over time, when that becomes permanent damage, now the signs and symptoms are permanent. But that is Charcot's neurologic triad. And again, that's tremors, dysarthria, which is speech and swallowing, and then nystagmus, which is difficulty with vision. Can be different perceptions. Double vision, a lot of times is what we see, or just double vision or just loss of vision, whatever the case may be. Rapid eye movements can be reported as well. So cerebral dysfunctions, you can see those listed. Each of these boxes is just saying signs and symptoms that have been reported. Obviously, you don't have to have all of these. And you can see that it literally can affect every area of the body. Depending on where that lesion is, will affect that message that's being received. Including sexual dysfunction and every aspect. Higher order also affecting higher order of thinking. So you can have anxiety, you can have depression, you can have a shortened attention span, just like I'm having trouble just focusing, and that can be higher order thinking as well. So, diagnosis, as I've mentioned, it's based primarily on history of manifestations, of keeping records of this started years ago, and now I'm finally putting all of this together, making sense of it all once I see and I find out about multiple sclerosis. I'm like, yes, this is it. It has followed this pattern. So keeping accurate records of that. And it may go off of looking back at their chart. They were in for this, they were in for this, they were in, in following that timeline to point to that definitive diagnosis. And once we have the history of the manifestations and presence of multiple lesions over time, you can even have, they were at the eye doctor several times. You pull all this together and it paints the picture of multiple sclerosis. Then we'll do an MRI, and that checks for the plaque and random scarring. It'll show lesions, and then that can lead to the definitive diagnosis. Also, this is something that will be, when it's suspected, there will be an MRI done, and there will be a follow-up MRI over time to show an increase in the lesions. Cerebral spinal fluid or lumbar puncture is going to increase the levels of immunoglobulin. And we're going to say, okay, there's obviously our immune system is working overtime here, and we can get the diagnosis that way as well. Medications and treatment. There are not a lot of things that we can do for treatment because there's not a cure. And as with the other two, MD and CP, we just want to help to optimize optimal outcomes for each of these clients, for these patients and these individuals. We want to know that we're doing the most that we can to help them with the signs and symptoms that they face, and knowing the painting the picture for each individual is going to be so different. Just as you've listened to this lecture, and as I'm giving this lecture, it's hard to wrap your brain around MS because it is so widespread. The central nervous system literally affects every movement, every motor pathway, every movement of the body, every thought process that we have. It affects our entire person in every area, in every way it can. So when there can be a lesion that happens anywhere within the central nervous system, it's so widespread, which makes it difficult to diagnose and to get a treatment plan. But once we know that this is what we have, we can help with what exacerbates this. Is there certain things, does stress play a part in it? Is what exactly are the things that maybe trigger it? And causes of MS it can be different genetic factors, just as far as being female, if that's going to increase the odds of that. It's generally is females, although males also are affected. And if there's an infection or anything that causes the prompting of the immune system to go into hyper overdrive or some type of infection, but it's still one of those rather vague disease processes that we're still trying to wrap our minds around because it is so widespread and difficult to diagnose. But we want to help promote independence and optimal outcomes for the individual. And knowing it's progressive, we want to be there, obviously, to keep the individual safe. So for in the instance, if you're having trouble with sensation on your legs, and we know when the bouts come, there can be potential for falls. We want to make sure that there are adaptive devices that can help this person ambulate safely. And so it's putting those things into place. Whatever the signs and symptoms tend to be for you, and you're going to be aware for those, making sure that resources are available to optimize independence, but then also to keep the individual safe. And we can obviously give corticosteroids are intended to help to decrease the relapses and keep you more in remission longer to help decrease the relapses. However, it is progressive, so it will help, but it's not going to cure. And then just trying treatment and progressive. There's also been a link to a decrease in vitamin D deficiency. This is still kind of out there and a little bit controversial, but we have seen a little ties in regard to North and South poles where there would possibly be a decrease of the cases being an increase in those areas. So that is something to think about as well with treatment of increasing vitamin D. And that, so you can see symptom management is basically what we're doing, symptom management, because there is no cure. Again, I have mentioned, please go to muscular dystrophy, cerebral palsy, multiple sclerosis. Please go to these main websites. You can look these up, educate yourself there. Primarily, if you have someone, know someone that cares for someone, an individual with one of these disorders, or you can talk to that individual themselves and find out about, that's going to be your best resource. But again, go on, look at those main websites. You can see the phenomenal research that's being done, increasing life expectancy and just making individuals be able to live a much more independent, productive life. Is amazing strides that we have made with each of these disorders, muscular disorders. So disruptions to activity and rest we have hit with MD, CP, and MS. If you have any questions with these whatsoever, please give me a shout out. Otherwise, you should have everything that you need. I've got recaps throughout the PowerPoint, some questions thrown in there. Pay attention to those. Look at those resources. Right here at the end of this PowerPoint, I'm going to hit you with just a few questions right here, and then I'm going to cut you loose. But upon assessment of a 6-month-old infant, a nurse documents unusual stiffness in extremities, and mother expresses concern that her baby seems behind other kids his age. You suspect what condition? So we're looking at 6-month-old infant. The nurse is documenting stiffness in extremities, okay? And a mother expresses that the baby seems behind other kids his age. You would suspect what? This would be CP, cerebral palsy. Again, early diagnosis, because this is a disruption, and that you're going to note early on, because it is, remember, permanent but not progressive. You're going to notice and diagnose this by milestones not being met at certain times, but with an early diagnosis. Which class of drugs is typically used to treat MS? What is the goal of the medication when used to treat MS? That is going to be corticosteroids. It helps decrease the edema in areas of demyelinization and improve clinical symptoms. So corticosteroids for MS. Why is it often challenging to diagnose MS? This is because symptoms are vague and very transient. So it's very unpredictable, and it's going to be different for everyone. Symptoms come and go, and they vary. They're so diverse. The signs and symptoms can impact nearly every aspect of the body. So a health log, keeping a health history, and those manifestations are going to lend itself to paint the picture for a diagnosis that then would be definitively diagnosed by the scan, noting the plaques and lesions. The cause of MS is unknown, but we do know the disease is perpetuated by what? And this is a faulty immunoregulation. So faulty immune system that for some reason has nothing better to do than start attacking your body. So faulty immunoregulation. Cerebral palsy is known by or contributed by low birth weight, placental insufficiency, so lack of oxygen, traumatic head injury, or infection in utero. These are all contributors to cerebral palsy. A diagnostic test for MD is what? This would be a muscle biopsy, can be a definitive diagnosis for MD. Also, an EMG or muscle biopsy are diagnostic tests for MD. Cerebral hypoxia is the root pathological cause for which disorder? So lack of oxygen to the brain is basically cerebral hypoxia. Which one? Which of our three? Is this a root pathological cause for cerebral palsy? Okay. And I also have some NCLEX questions that we can toss out here. You can feel free to listen to these if you would like. This is extra here. Which of the following statements, since you're not going to be able to see this, I'm just going to read which answer would be correct here. Which of the following statements made by a patient diagnosed with multiple sclerosis would alert the healthcare provider that the patient requires additional instructions about the disease? These are going to be the correct answers, what I'm going to read first. It's important to inspect my skin daily, making sure there are no injuries. Can be that loss of sensation. So as with anything neuropathy, pins and needles, the tingling, you're going to want to know that you're inspecting your skin daily to make sure it's free of injury. Regular exercise can help reduce fatigue and help improve sense of balance. That is true. Regular exercise can help reduce fatigue and improve your sense of balance. Someone with MS would like to avoid foods that are high. This is the one that's not correct. I will avoid foods that are high in fiber to prevent problems with my bowels. No. We want someone with MS, anyone really, but specifically with MS, to have a diet high in fiber. That's going to help the bowels. And then let's see, a warm bath in the evenings will help relax muscles and relieve pain. Okay, you do not want excessive, since there may be a loss of sensation. You're not going to want anything in extremes, not in extreme cold or not extreme hot. And then use of stress reduction strategies can decrease severity of symptoms, and that is true. Decreasing stress is going to help anyone, and but specifically someone with MS. That is just another thing to throw in. You can, I have some NCLEX questions. If you want to go over these, I will glad to. I don't know if they're hooked into your Harvey PowerPoint or not. If they're not, reach out to me and I will get them to you if you would like further NCLEX prep questions related to disruptions for activity and rest. So long for now. Those, you'll have the 3 videos now for disruptions of activity and rest. If you have any questions, please reach out to me. Otherwise, I look forward to seeing you face to face very soon.